Hey, welcome. My name is Gary Gaddis. I'm the co-chair of AAEM's Aging Well and Emergency Medicine Interest Group. On this episode of EM Emergent Journeys, we offer an edited conversation between Thien An Nguyen, a member of the Resident Student Association, and AAEM board members Kevin Reed and Robert Frolichstein regarding what's kept them interested and engaged in our specialty, not just for a few years, but for a few decades. Welcome to this two-part series. Part 1 will begin momentarily. Please note, we divided this edited conversation into 2 blocks. On behalf of our interest group, we hope that you will learn some strategies that you can adopt for yourself toward increasing your career satisfaction from our engaging yet demanding specialty.
Hi, everyone. My name is Thien An Nguyen. I'm an MS2 at the Ann Burnett School of Medicine at TCU in Fort Worth, Texas. And this was my first year at an AAEM conference where I met these 2 lovely folks. I rolled up to the 7 a.m. meeting for Aging Well in Medicine because I misunderstood the title, actually. I read Aging Well in Medicine. I thought it was about burnout. And I was like, well, that's my main fear with joining emergency medicine. It's such a controversial topic. I roll up and then I realized I was way under the age average. And our conversations redirected, but were very fruitful. So I'm excited to rediscuss all those topics.
Excellent. Well, thanks for that conversation that morning, and hopefully we can recreate some of it. And thanks for going to essay. My name is Bob Frolichstein. I'm a community emergency physician in San Antonio, Texas, where I've been here now for, 25 years or more than that in San Antonio, and been involved or been a member of AAEM since 1997, I believe, but been actively involved probably the last 10 or 12 years. Been on the board the last 6, I think, or 7 years, and the current president of AAEM.
Also very excited to be here. I'm Kevin Reed. I work at MedStar Georgetown University Hospital in Washington, D.C. I've been practicing emergency medicine close to 25 years come July. I've been active with AAEM in various boards for probably about 15 years, and most recently was elected as an at-large board member about a year ago. Also joined this committee about a year ago, and really looking forward to our discussion about aging well in emergency medicine and kind of what that means to us.
Yeah, absolutely. So I think the main opening question that day I asked was, what kept you guys in it? What kept you guys in emergency medicine for all these years? And how did you make it out? I think that's a pressing concern for all of us entering or interested in emergency medicine.
Sure. Going through med school, you find the thing that you're passionate about. And I think I was very fortunate to find EM in one of my last rotations and be like, thank God this is where I needed to be. So I kind of found not as a calling, but it was just the place I felt most more comfortable. Why I'm still in it is I just love taking care of the patients. I love the teamwork. It's a true team sport every single day. No matter what's coming through the door, you have the team to help back you up and assist you when patients are in their time of crisis. It's camaraderie. It's highs and lows during your shifts. You can have some very challenging shifts, and you need people to really support and kind of help you get through those and move on. And then you have some other ones where you make that amazing save or diagnosis, you kind of change someone's life and trajectory. Even something is intervening, that's the one day they decide they'll talk to your substance abuse team about stopping alcohol. That's a life-changing event for them, and you're part of that. So I think there's a lot of fulfillment at the bedside medicine, and I think emergency medicine also is a specialty where you do have some flexibility. You can pursue other things. I was heavily into education for many years. I very much enjoyed that, and then move more in kind of administrative, and then kind of that larger 10,000 foot view of how can we change as a system, and also being on the board allows that idea of what is the future of emergency medicine. And so it's been a nice career to be able to dabble in different things and find that final joy or what you're most passionate about as you move through your career.
Yeah, it's going to be hard for me to come up with much different than what Kevin said, but I'll give it a try. I think I just calculated. I'm a PGY 34 now. PGY 34. I've been doing this a while, and it's a tough job. It is a hard job. But if I look around the house of medicine, there's no other specialty that I'd want to do. This is by far and away the only thing that kind of fits me for much of the same things that Kevin said. And again, it's a tough job. And some days you just kind of feel beat up. But even on those tough days, I've always been able to focus on one patient encounter that that exemplified why I'm doing what I'm doing. Either you helped that person in a dramatic way, or you were just kind to them and that was noticed and appreciated. And so you just got to focus on the small wins. And that's really what's keeping me going. And Kevin, I've done many non-clinical aspects of my job. I've led my private group in San Antonio for 14 years. That consumed a lot of my time and energy. But at the root of it all, what was I doing in that job? I was helping people. It just happened to be my colleagues, my co-owners of my group, right? So, and then if I look outside of medicine, I don't know. I can't find anything that I would do that could give me the same real satisfaction that fits my skill set and things that I'm passionate about. Why not keep doing it is the answer to my question, or the answer to your question, I think.
I love that. So you're talking about a private group. Is it emergency medicine related or something tangential to that?
No, it's my emergency medicine group, my Democratic group in San Antonio.
Oh, I see. So you talked about being a P2Y 34 now. Your expectations before joining emergency medicine and now, how has that evolved? Like your expectation versus reality for both of y'all?
Interesting. Yeah, so not all those P2Y years were as an emergency physician, because I was in the military, and the military does some kind of crazy things. And after 1 year, they send you out and act like you know what you're doing. And so I was a general medical officer for 3 years, but then the rest was all emergency medicine. And actually, ironically, when I was a general medical officer, I was working in the emergency department. I had no clue what I was doing, but I think it went okay.
But you made it out.
I think it went okay.
And everyone else made it out too. That's even more important.
Exactly. Anyway, sorry. To get back to your question, I don't know that to some extent you kind of don't know what you're getting into when you're doing this, but I think it's everything I thought it was going to be and more, actually. And when I was younger, I think we probably all do. We love the kind of excitement, the adrenaline, the high pressure cases that you go in there and you intubate somebody or whatever. I love that. And I still do, but I will tell you, I get less satisfaction from now than having a heart-to-heart conversation with a family or a patient that's not going to do well or has been through a tough time or something like that. I got two quick stories that I'll I think, exemplify this, if you'll bear with me. This was I'd probably been at Methodist Hospital, which is the hospital system I'm with in San Antonio. I'd probably been there maybe 3 or 4 years now. And the front of the hospital, the doors open up and the stretcher comes rolling through, and this guy's laying on the stretcher and the tech's standing on the edge of the stretcher. Somebody else is pushing the stretcher and then they're pushing on his chest. And I've been out for a while, so I kind of immediately recognized this was not good. This was not a good scenario. But we got him in a room, and it was just like perfect emergency medicine. We got him intubated, defibrillated, and just by the way, a cardiologist happened to walk by, and he was on call, and they took him off to the cath lab, and he did fantastic. So it was all that, everything you want a case like that to be. And as an aside, I saw the guy about a year and a half, 2 years later in the emergency department, and I said, "Oh yeah, I saw you once in October of blah, blah." And he said, "Oh yeah, that was the year Dr." And he named the cardiologist, saved my life. So fast forward, probably maybe 10 years later, had a very sick patient, very similar, was in septic shock. And she's old, very debilitated baseline. And I spent probably 30 minutes talking to the family about what they wanted. And ultimately we decided to just let her pass and just comfort measure only. And they thanked me and hugged me afterwards. And I get just as much satisfaction from that kind of interaction than I did that cool one at the time.
Both powerful.
Yeah, no, I would say, for example, for the question, perspective versus reality, the idea of, like Bob said, is coming out and being the cool trauma and all those amazing things coming out as an attending. And then the reality is it's a lot more than that. There are those amazing cases like that, and the procedures and things, those simple victories, the kind hand that says, I appreciate what you did. I thank you for what you did, or helping someone through those challenging conversations. I remember kind of similar case, but all in one. A patient came in critically ill, and I was working with the resident at one of our community sites. And I kind of looked at it and I said, that patient's going to code in about 5 minutes. Like, you just get to that point. Sure enough, they did. We got them back. They had a ruptured AAA. And we were literally about to fly them out when we talked to the vascular surgery team. It was going to take them because we were a community site, and said, you need to be very frank with the family about expectations of what's going to happen should we go to the OR. We paused before they got on the helicopter, talked with the family, and the family said, you know what? Mom would not want that. She would not want to live that way, that she was going to have all these disabilities and things after. And we ended up doing a compassionate expectation with the entire family. And they had police and EMS and fire, because I was part of the family. There must have been 25 people there when she passed. And it was just you remember those moments, like Rob said, and we all have them in our head. You will have them in your career, where it's not just about what you can do. Sometimes it's better to say, should we do? And helping the family through that with your experience can be pretty amazing. And on the expectation side, I think things have changed a lot. No one talked to me about charting, billing, coding, or things when I was a resident. It's nice to see that's part of residency now, and much more on just the practice of medicine, because there is a business aspect to it that is very real, and needing to learn those skills. And we're going to be switching from one major IT system to another. PGY 28, I'm going to have to learn a whole new IT system. There's change is inevitable. So I think that's one of the things you don't realize. The cases can change. They might be the same or similar to the patient population, where you work, community, et cetera. There's all different things, flavors of ER, but the change to ER in a practice will be constant. But I kind of like that. That's part of the reason the ER is great, is every day is different. You have no idea from day to day what you're going to see. And so it's been nice to have a field that continues to change. Some are a little more bumpy, like a major IT switch will probably be a little more bumpy, but get by, you'll move on, and you'll still care for patients, which is why we do what we do.
No, those are powerful stories, seeing the iconic EM story of the patient coming in and then you saving him right away, like your first story, and then how your perspective shifts to more of the serious, deep talks, taking the time to really sit with the family. I feel like the stereotypical emergency medicine type of doc, like, I don't really think of the emergency medicine doc being able to take that time to sit down and having those meaningful conversations with the family, but that's really what medicine's all about. Do you think stories like that have kind of changed or altered your perspective on why you did medicine over these years?
I think it revealed it to me. I don't think it changed it. I think it revealed it to me. And I don't know. I probably in my med school letter, I probably wrote, I want to help people and all that. But I don't think I really believed it until you encounter those kind of scenarios. And for me, at least, it is typically those little small things. Now, that's not a small thing when you talk to family about comfort medicine only, but it can be even smaller than that, right? It can be somebody just saying, oh, wow, nobody's ever really told me why it's so bad to keep doing methamphetamine or whatever, and acted like it was a person and they cared about him or whatever. Pick your drug of abuse. Sometimes it's just simple things like that. And back to that story, that 30 minutes was not continuous. So know that also. This is emergency room. There's very rare you get to sit down with somebody and spend 20, 30
You're probably getting yanked out of that room.
Yeah. It's just in and out. But that's a skill that you develop and you learn. And I think that's I've often heard that from non-emergency physicians that they couldn't do emergency medicine because they can't develop patient relationships. And I actually think I don't think that's true at all. Now, they may not be sustained over years, but I think we are in a great environment to develop some very deep, impactful relationships, because it's often very intense and you can just kind of circumstances force you into it. And I actually enjoy that. I like the challenge of, okay, I got 3 minutes to kind of win these people over and make sure they understand that I care about them as a person and I might actually know what the heck I'm doing. And so I kind of enjoy that challenge.
Yeah, I would agree. It's funny, as you're talking, I'm trying to think of my response, and a couple things popped up, but I think one thing that popped up was one of my mentors from my residency told me over a third year, he would go through all the different diagnoses of emergency medicine and tell you how to be a good doc and how to be a good attending. But he would say two of the most important things about a successful patient encounter is realize there's a patient complaint and or a patient and family agenda. And the example he gave, he got frustrated during residency and his residency director was talking to him and he said, "Why are you so upset?" He said, "Well, it's 2 a.m. There's a guy with a cough for 3 months coming in. He wants an x-ray. He's fine." Turns out the reason he came in is his brother had died from lung cancer about a year before. He started out with a cough. So he had a cough for 3 months. Why did he come in? His complaint is a cough. What's his agenda? Do I have lung cancer? So he did the x-ray, reassured him, he went home. And to Bob's point, that was such a simple thing right there, but he took time to listen and found out the why. And I think that's a lot of what we do. What is the why that the patient's there? Can we, if it's a chronic complaint, can we help them? Can we explain it in some way or reassure them or put them on a path? No one's ever told me I should probably see this doctor, or no one's ever explained it to me that way. And I think that's much more than pattern recognition. That's just getting to know people, getting to meet them kind of where they are. And I agree, I'd love to sit for 30 minutes for every patient, maybe some more than others. But I think there's pattern recognition of, oh, that looks like a kidney stone based on what you're telling me. There's a pattern of, okay, I'm not connecting with this patient or family. They're still looking at me like I have 3 heads when I try and explain this. And you have to pause and recognize that and meet them where they are, or trying to find another way to explain it or help them without adding massively to your day, but it may add massively to that patient encounter to make it a positive encounter, or to, again, put them on a path where they feel like you've helped them in some way. We always can't help everybody, but that is, I think, a very unique thing. Even though to Bob's point, you may have 3 minutes, 5 minutes, 8 minutes, you can be very impactful and you meet people sometimes when they're extremely vulnerable. So while it's not a long-term relationship, I think it can actually be a very intense, brief relationship just between a few people in a room. And it can be extremely gratifying, I think. Just that simple thank you can really go a long way.
You bring up a really good point. I'm just going to touch on it as well, is that after a while, every appendicitis looks pretty much like every other appendicitis. But each person who has appendicitis is different than the other person who has appendicitis, or pick your pathology. And that is one of the things that keeps it fresh for me, is make it about the person, not the disease, not the kidney stone, not the disposition. Make it about that person. And a big part of that is what Kevin was saying, is understand why they're there. And sometimes that's pretty challenging. And sometimes it's not even related to the chief complaint. And so
Absolutely.
you have to just be in tune with that. And again, it's one of the things that kind of keeps it fresh.
Yeah. It's that gift y'all have to have of establishing that trust so early on, so the patient really opens up in the limited amount of time. How do y'all do that? How do you go in there and instantly become their best friend? I feel like that's so unique to emergency medicine, because there is a long waiting room, but you don't really see the patient until they come in for that tiny short encounter, versus having a patient you get to sit down with and truly have that. Like you said, you had a 30-minute conversation. It was very broken up. You were getting yanked from room to room. It's very different. How do you establish that trust to show them you're really there to listen to them?
I don't know if there's one answer to that question. There's books written about this. There's techniques that are thrust upon us that aid it, and those kind of techniques to do it. But at the end of the day, I think it boils down to acknowledging them as a person, and especially early on in the encounter, a person, not the patient in bed 8 who's complaining of belly pain, right? Or a person. And there's various ways to do that. And I typically will start my patient encounters talking about something that's not related to why they're there. I'll notice their t-shirt is whatever. They got a Dodgers t-shirt on, and we talk baseball for a second, or just, I don't know. There's various things that I can't say that there's one prescribed way I do it, but the root of it all is that you acknowledge them as a person, and then also show them that you're a human. Also, you're just not an automaton. You're not an AI computer. You're a person. And I don't know if that.
Yeah, I agree. There's a lot of data and science about it, but it really comes down to, I guess, just being, to your point, meeting where they are. Ideally, same idea, you see some sports thing or other, you walk in and you kind of bring that up. If they have a long wait, you start with just an apology. Say, "Hi, patient, Ms. Jones, I'm really sorry I had a long wait today. You must be uncomfortable, but I'm here to help and here to listen." Things along those lines. sitting down with them, greeting the people in the room with them as his family, friends, significant other. You're recognizing everybody in the room. Lots of techniques, but I think we all find our own. But I think it's it's not being an automaton. You're a physician, but you're a healer coming in to meet that patient, and checking in on them, I think, helps out a lot. But yeah, just trying to do what you can to establish trust early, whether it's saying, hey, I know you've been sent in by your physician. I took a look at their note. I understand this is what's going on today. Is that correct? Or if they look really uncomfortable, saying, would you like your wife to tell me what's going on today? It looks like you're uncomfortable. Sure. Just picking up on those cues, I think, and trying to make a connection early, I think helps out a lot.
Yeah, you just reminded me of something. It can be something as simple as, I've been with the same system now for 24 years, and the patient's personal physicians, I know a lot of them. I can make it a connection that way. Say, oh, I know, or whatever, and we're good friends. And most people typically like their personal physician. So a lot of different ways to do it. But you do have to be conscious about it. If you approach every patient as the 34-year-old in bed 8 with belly pain, you're not going to do that. And you're doing a disservice to the patient in that regards, but you're also doing a disservice to yourself. And I think, again, this is a long career, and you got to find those little gems of satisfaction. And if you don't approach each person as an individual, you're not going to find enough gems to keep you going.
Yeah. Humanizing the medicine. I feel like that's probably why it's way more fun being out there in the hospitals, meeting these people instead of right now I'm just in the books. I read a 34-year-old patient. I'm like, not this again. Like, it's just A, B, C, D. You have the whole story. So I understand how humanizing makes it more impactful for them and for y'all probably. But their primary care physicians are lucky because they have that continuity in their care. Do y'all ever think about your patients after they leave the emergency department?
Certainly, yes. And I used to be better about this. I don't know if it means anything that I'm not, but I would often go look up people that I admitted and go look up people and find out what happened, and probably not as good about that as I used to be. I don't know why, but yeah, you think about them, and I don't typically worry about them. And some of my colleagues do tend to do that. And I think that eats you up. And my approach there is I genuinely do the best job I can for each patient. And I consider, well, I've been doing this a pretty long time. I'm very well trained, and I took their complaint seriously and did what I think was the best thing. And if I happen to miss something, well, that happens in life. And it wasn't because of lack of effort or lack of caring. And that's my approach. And it keeps me from really worrying about those cases.
Yeah, I think similar. There are the ones where you admit them and you're not sure what's wrong with them. So it's a knowledge thing of just saying, oh, that's what they ended up having. So it's like kind of a neat clue. You want to put the pieces together. The puzzle doesn't fit in the ER. You get all the pieces later. There are ones where they're very sick and you wonder if they made it through the night. So you check in your next shift. So you're just like, I wonder what happened with them. But I think occasionally there is a connection you have with the patient or family for some reason. And I don't do this often. Last week, I went up to check on the patient the next day when I came in. So I think everybody, we have docs on our team who call a couple of their patients back from every show. I think everybody finds their way. But yes, there will be to Bob's point, we are not all perfect. There's something that I did my best, but I missed X diagnoses. That will be a case everybody will have in their career. When you can see that as a learning opportunity to move on. I think everybody develops little connections, and once in a while there's a little bit something further, or they send you a letter, something like that. And you're like, oh, wow, that was really nice. I didn't realize they enjoyed the care that much. And that makes you feel good. So yeah, the reminders come up sometimes intentionally, some unintentionally. When you get a call, hey, do you remember that patient from yesterday? And you're like pausing and waiting for what's going to come. But yeah, patients stay with you in different ways, I think.
Wow. No, yeah, that's awesome. That's insightful to know because it's hard for me to imagine that. And so I'm actually thrown in that situation. And that will be in a little bit longer. I'm just a second year.
And it's being with the same system a very long time. It's amazing how many repeat customers I've had.
Really?
And oftentimes that's because they have chronic problems or failures of the system or whatever. But sometimes that it's for a totally legitimate reasons they're coming back and they happen to see me again. And then they'll say, "Oh, I'm so glad you're the one on," or something like that. And it does make you feel good.
That would make me feel good. I'd be like, really? You mean that? A lot of how emergency medicine being shift work, that's very different from a lot of different specialties. I think the main, like I go to some of my interest group meetings at my school and they'll talk about, the best way to fight off burnout is you leave it all at the hospital. When you go home, you just decompress and you have that shift work up. You have your work and then you have your life after that. How do you think that actually compares to what people are teaching? What do y'all do? Do you go home and do the stories kind of linger with you? Or is it just, I'm a doctor here and then I'm whatever, a dad or whoever else at home?
I will say that I tend to be the not bringing home with me. And so far as that, I can probably count on one hand that the times I've come home with incomplete charts because it's just, I want to be done. And I finish my charts at work and I don't come home until I'm done. And I still don't really talk about my experience with my family that frequently. People always say, "Oh, I bet you got some good stories." I really don't have that many good stories because I do tend to leave it I compartmentalize really well, which is, I don't know if that's a healthy thing or not, but that's what I've done over my career and it's worked out okay.
You seem pretty happy and normal.
All right, we actually have that on recorded line. You are normal. I can share
Let me
voice
take that
meeting.
snippet out. I
You are
need to know.
normal. Like your kids, everything. That's awesome. That's great. Yeah, I guess if you couldn't do our job, if you always brought your work home, it would eat you up personally and with your relationship. So that doesn't mean there isn't a case or a day that you come home and it's a tougher day than one before. I think some of the hardest days have been more administrative issues, not so much the ER work, where there's a challenging nut you're trying to crack or work through, or all of a sudden something goes off and you have to very quickly fix some process or others. I think that there will be days where you bring stuff home, but I agree, compartmentalization, I think, is part of the job that later is shipped in after. It doesn't mean you're not human. It just means that's the way you continue moving forward. I think I'm maybe a little more fortunate in some ways, but again, I can't compare because it's what I know. My wife's also a pediatrician, so we can share things. She does a lot of PGR work. So sometimes we talk through a case or share frustration. So sometimes that's therapeutic for us. Again, that's what I know. And I think it kind of helps. But yeah, at the end of the day, I think being able to compartmentalize is part of it. There's definitely lots of information and discussion about when it gets to be too much. And one thing that we have in our system, which I think is very good, I'm guessing other systems have something similar or groups. We have a process called care for the caregiver. When you have a very tough case or something challenging or even something personal, there's a huge amount of resources available that have nothing to do with your chair, your vice chair, your colleague. It's a total separate, maybe probably a doc or other, but they're there just to listen to help you out. And I personally engage with them a few times because it's been very helpful. Sometimes you need someone outside of your sphere of influence who knows you a little bit, but doesn't know all the baggage and everything else about you to help you out. And I think that's a change. I don't think that was available when I started in my career. The resources and things there to say, hey, it's okay to be human. It's okay to cry in front of a patient and family. It's okay to be troubled by what happened. And I'm glad that's part of where it is because I think that was sorely needed for a while. And I definitely seen to help colleagues through some very tough times, not always work related. Life throws you a lot of curveballs at you and you still have a shift to work. What are you going to do? So my perspective.
Exactly. Do you think over the years, emergency medicine has evolved to where at one point it was more cold and cut in stone? Or has it always been this compassionate, deep connection?
Well, it has evolved. I don't think that it's, at least for me, it hasn't changed as far as the connection and compassion and all that. I think it's more complex than when I started. Our patients are just sicker and we have multiple comorbidities. They're surviving things that 20 years ago they didn't survive. And so that's great, right? And we actually welcome that challenge. And we also have more tools available to us. Just so many more tools. When I started emergency medicine, if a patient came in with chest pain and it was a scary story, I was pretty much done. I'd admit them. Nowadays we got troponins, we got triple rule out CTs. We got all these tools that it's great, right? Because we can identify those patients that really need to be in the hospital versus those that don't. But it does make our job much more complex. It's so much easier from a workload perspective to say, oh yeah, that's a really scary story. I'm going to admit you and the cardiologist is going to see you in the morning and talk. It's just so much easier to do that. It's not good. It's not necessarily good for the patient. It's probably not even good for us. So this is probably a better way to do it, but it does add complexity and difficulty to our job. So it's evolved that way. Emotional stuff has changed it all.
Yeah, I see. I just wonder where that stereotype came from. Because I think before going into medical school, I never even considered EM because I just imagined a gruff doctor that's, hi, how are you? I'll give you this medicine, this big shot. And so I never even considered emergency medicine until I shadowed Dr. Pola in Fort Worth, and I fell in love with it. I was I don't know if I'm in love with how she treats her patients or if EM, but that just really drew me in, how she talks to them, connect to so many patients at once. I was oh my gosh, it's not what I imagined of a gruff doctor being hey, here's your medicine, now leave. So I just wonder if at one point it was ever like that.
Yeah, I guess I would say that I feel like I had great teachers and mentors that were very warm, caring, giving in my residency training program. So I never thought of it as that. There are challenging cases and tough patients, and those are just different flavors, but it's the same thing that comes through. It's just a different reason. I agree it's become more complex because of how much we can do in the ER and what's expected to be done prior to calling about admit to X or Y or this or that. The use of ultrasound, different tools we have that we didn't have. I think the technology change is big. And also just the fact of when I started, we didn't have certain check boxes to check off for sepsis guidelines and a lot of these other things that you kind of have to do now to keep your certification for stroke. There's just some complexity today, but you build processes around it. That's the way you do it. You build an IT system that gives you a heads up, hey, they have SIRS, are they septic? Or make sure if you document sepsis, a box comes up and says, you need an autophrase for sepsis, please add this to your notes. So there are workarounds of it, but there's definitely a little more complexity to it. But the one-on-one patient interaction, the teamwork, the care environment, that's the same. I agree with Rob. That I think I'm better at it now, hopefully, than I was when I first started. But that connection with the patient or family or helping someone out while we do what we do is still there.
We hope you have enjoyed this podcast from the American Academy of Emergency Medicine. AAEM is a nonprofit professional association of over 8,000 emergency physicians dedicated to board certification and democratic group practice. For more information about AAEM, visit our website at www.aaem.org.